Well, good afternoon, everybody, and welcome to OneWelbeck Heart Health and to this 1-hour webinar-based session on modifiable risk factors in heart disease. My name is Mark Westwood. I'm a consultant cardiologist here, and I'm joined by 3 respective experts who are listed below. So Mark Earley, Sunthar, Kanaganayagam, and Neil Chapman. And they'll each be doing about a 12 to 15 minute presentation as outlined below. And then at the end, we'll have a question and answer section, which will be based on the question, which you can submit. And the easiest way for you to do that is if you look towards the bottom of your screen and towards the right side of it as you look facing it, you'll see a selection of things. And the one on the far right is Q&A. And if you type your questions in there, we will answer them at the end, but also as well where possible, because we know time is limited for everybody, where we can, we will answer your questions as we go along. So if you could try and use the Q&A for the Q&A, if you do accidentally pop it in chat, which is also down there, that's not a problem. We'll just keep our eye on that too and move it across. And that's really all I have to say. So I think without further ado, we'll get going. And the first talk, I'm delighted to welcome Mark Earley, a colleague of mine, known for many years, who's an electrophysiologist. And unsurprisingly, he's going to talk about atrial fibrillation and more about the causes rather than some of the treatments to which he spends a large proportion of his time doing. So without further ado, Mark, I will hand over to you.
Great. Well, greetings from Hertfordshire. I hope you can all see my slides. I'll get a thumbs up from Mark if you can. And yes, atrial fibrillation is the only thing I know about, according to Mark. Thank you for that introduction. So I'm sure as a general practitioner, you're extremely familiar with atrial fibrillation and you're aware of this epidemic, this huge number of cases that we see, particularly as patients get older. But even in younger populations, we're seeing about maybe 200,000 people in the UK under the age of 65 who have atrial fibrillation. It's an extremely common condition that causes breathlessness, causes palpitation, reduces people's exercise tolerance, etc. But by far the most important thing is that it causes stroke. And the only important treatment for atrial fibrillation is, of course, to prevent stroke. And strokes in AF are very bad because it's not usually due to the buildup of atherosclerotic plaque that allows the brain some time to get ready, but it's usually an acute embolic event, and you get much worse strokes with atrial fibrillation than let's say, normal strokes. So this is my simplified formula for the management of AF. No matter how you pick it up, through screening because the patient's symptomatic or completely incidental, once you've diagnosed AF, you need to control the heart rate and then look for reversible causes, acute alcohol intoxication, hypothyroidism, etc., that can be treated and to prevent AF recurring. Then after that, obviously, assess the CHA2DS2-VASc score and treat with warfarin, or more commonly now the DOACs. And finally, if there's ongoing symptoms, despite good rate control, then we have the opportunity to try and restore sinus rhythm. And so we've got these 3 pillars of management of atrial fibrillation: stroke prevention, heart rate control, and rhythm control. And I've listed some of the treatments that we use. Now, the problem is that people like me have been bleating on about atrial fibrillation ablation and the ability to cure atrial fibrillation for a long time now. It was discovered, and this is a cartoon of the atria. Here's the right atria with the superior and inferior vena cava and the tricuspid valve. And this is the left atrium with the 4 pulmonary veins coming in, and then there's the mitral valve. It was discovered that cells behave badly where the atria meets the pulmonary vein. And these cells can fire off very rapid electrical signals that conduct rapidly, cannot be conducted uniformly in the atria. These wavefronts break up to give this chaotic activation that characterizes AF. And by taking catheters from the right leg into the right atrium and into the left atrium, we can actually cauterize or freeze, different techniques, the cells to essentially create a line of scar which then isolates these rogue cells and prevents people getting atrial fibrillation. It is a fantastic treatment. But if we've got these fantastic treatments, why are we not seeing the prevalence of atrial fibrillation come down? And the reason for that is that we have this huge growth in developed countries like the UK of risk factors that underlie and potentially cause atrial fibrillation. And I've listed some of those here, which I'd just like to explore a few of them in some more detail, and then discuss perhaps a new paradigm for the management of atrial fibrillation. So there is an extremely strong link between obesity and AF. Now, the data are observational, but extremely compelling. If you look at the Framingham study, for every 4%, for every unit increase in body mass index above 25, there's a 4% increase in the incidence of AF. There's a huge 50,000 patient gene study that looked at variations in the gene profile, and the variants that were associated with a high BMI very, very strongly were linked to getting atrial fibrillation, suggesting it as an independent risk factor. And then in another huge meta-analysis study, it looked at every 5-unit increase in body mass index led to an overall increase, 29% per 5 units in the incidence of AF. And then for patients undergoing surgery or undergoing ablation, much greater increases in the recurrence of atrial fibrillation in people who are overweight. And there are really good pathophysiological reasons for this. Essentially, obesity puts a huge strain on the heart, increases hypertension, increases afterload for the work the heart has to do, and that leads to left ventricular thickening and enlargement of the left atrium. There's also extra pressure on the right ventricle through the mechanisms that also cause obstructive sleep apnea. And then there's the direct issue of having lots of fat around the myocardium and the pericardium of the heart that can have a direct toxic effect on the cells that are generating the action potentials. And that combination of the structural remodeling and the electrical changes predisposes people to get atrial fibrillation. So does reducing body mass index actually reduce the amount of atrial fibrillation? Well, this is a large, the Legacy study, a large Australian study, where they put patients who had a body mass index over 27 and had a diagnosis of non-permanent atrial fibrillation, so either persistent or paroxysmal atrial fibrillation. They were put on both a weight and an exercise program. So the graph on the left here is patients who didn't have any specific treatment, drugs or ablation for their atrial fibrillation. We can just see this is their freedom from atrial fibrillation survival curves. For those that managed to get a weight loss of greater than 10%, much less atrial fibrillation than those that weren't able to achieve any weight loss or only moderate amounts of weight loss. And if you then combine that with the use of antiarrhythmic drugs or the use of catheter ablation, again, as you'd expect, the patients who did best were those who managed to lose at least 10% of their body mass index. Those that did worse were those that either put on weight or lost less than 3%. So there's very compelling evidence to support the treatment of obesity to prevent atrial fibrillation. And in the same study, they also looked at exercise. So patients were put on a moderate exercise program as described here, and it was seen that the incremental gain in cardiorespiratory fitness, which was judged by greater than 2 metabolic equivalents improvement in their maximal fitness. So for patients, again, who didn't have any drugs, those that were able to gain their fitness the most had a much greater reduction in the amount of AF they got. And if you then combine this with treatment with drugs and ablation, again, a huge reduction in the burden of atrial fibrillation for those that were able to improve this fitness. This is actually looking at those who weren't able to lose weight and those that were able to lose weight, sorry. And so those that were able to lose weight and improve their fitness did the best of all. So the interesting other side of the coin is if you look at the sort of elite athletes, those who are extremely fit, they interestingly see an increased burden of atrial fibrillation. And this is from a meta-analysis looking at different types of athletes. I particularly like the professional cyclists. I'm into cycling. So this was comparing professional cyclists from Switzerland who competed in the Tour of Switzerland versus professional golfers from Switzerland. And they saw all age matched controls, much higher incidence of atrial fibrillation in people who've done elite sports. However, that didn't translate into an adverse outcome in the long term. So they didn't get more strokes or any other cardiovascular disease, but they do, probably through separate mechanisms, get more atrial fibrillation. Another important subject is obstructive sleep apnea. So we know some people, when they sleep, will obstruct their upper airway, leading to intermittent interruptions in their ventilation. And the huge swings in the intrathoracic pressures can cause increased return of blood flow to the heart, again increases the afterload on the heart. And then those intermittent hypoxic episodes also has a direct effect on the electrics of the heart, both leading to atrial fibrillation in the long run. And we know there's been various studies in the normal population, those without AF, the amount of sleep apnea is between 3 and 49%, but much higher incidence of sleep apnea in AF populations. And so it's really important to ask all new patients with atrial fibrillation to see if they have any symptoms to suggest they might have sleep apnea, such as the ones that I've listed there. And a lot of these will require the partner to tell them about episodes of choking, gasping, actually stopping breathing during the night. A useful thing that our anaesthetists promote, because it's an important thing for patients undergoing general anaesthesia, is the Stop Bang questionnaire, which just asks 4 simple questions about potential symptoms, and then also some additional measurements. And if you score more than 3 in that system, then you should be referred on for some sleep testing. Now, the gold standard for sleep apnea testing is to have an overnight polysomnography test. Now, that's a labor-intensive thing that goes in a specialist clinic, and it's very difficult to do as a screening test. But essentially, that will measure the number of apneic or hypopneic episodes you're having every hour. And if you're having more than 30 an hour, it's severe, down to mild, between 5 to 15. You can get kits that you can use at home, and the one that we've got at the WellBeck, these very simple devices now that patients can take home, wear at night. It does do some recording of their sleeping, measures their essentially their nocturnal saturations, and certainly is very good for picking up the severe end of sleep apnea. It's very successfully treated with CPAP, and then this is a study that looked at patients undergoing atrial fibrillation ablation, and for those patients with sleep apnea who had an AF ablation but were not treated with their sleep apnea, they did much worse than those patients who had obstructive sleep apnea and were treated with pulmonary vein isolation. So it's an important treatment to prevent the recurrence of atrial fibrillation. It's an important treatment for their symptoms anyway. So I'm not going to run through every risk factor because I'm running out of time, but you'll all be aware of these other important things that can impact on cardiovascular disease and also have a direct effect on atrial fibrillation as well. So what can we do about it? So we now talk about the 4 pillars of the management of atrial fibrillation. I mentioned the first 3, but aggressive risk factor management is also important for all our patients and for those who are undergoing interventions with drugs or ablation. And so I would see myself as part of the AF management team, focusing on preventing strokes, looking at possibilities for treatments of their atrial fibrillation. But an essential thing is also the risk factor management team. There are specialist clinics. We're setting up a secondary prevention clinic, Of course, that's an essential role in primary care to really target patients, all the things that can lead to their AF. And this is my final slide. It's quite detailed. I'll leave you to ponder on that later, and I'm sure Rupal will send that out to you. If a patient comes to you who's got angina, you don't think, they need a stent. You tend to think about the whole cardiovascular risk, their diabetes, their hypertension, their lipids, etc. I don't think we automatically think in that way about patients with atrial fibrillation, but it's clear from all the evidence that's available that we should do. And it's not just about doing an ablation, it's really about managing their risk factors carefully. Thank you very much.
Thanks very much, Mark. A fantastic talk, and I particularly like that last slide, which we've left up for a couple of seconds. I think a really holistic way to think about atrial fibrillation, as of course we should be thinking about all medical conditions in a much more holistic and joined up manner. Okay, well, without further ado, we will move on, and the next presentation is going to be by Sunthar. Sunthar is also a consultant cardiologist. He's over at Imperial, and he's a specialist in heart failure and imaging. So I will leave him to crack on with his talk.
Thanks very much. Can you see my screen okay?
Yes.
Great. Okay, cool. Thanks very much. Thanks for the introduction. So yeah, I'm going to use my 15-minute segment to talk about heart failure and valve disease. I'm going to update you on some of the NICE guidelines just because they were updated late 2018 for heart failure. And some of my slides that I've got in there are really there for your reference for later on once the slides have been sent round to everyone. And I'll touch on valve disease, and I'll integrate the talk with lifestyle issues, as you've already heard. So essentially any patient with breathlessness, any leg swelling or lethargy should all trigger you to think that this could be heart failure. And you know, we don't necessarily see a patient who's lethargic, especially in the COVID era, and think necessarily of heart failure. One of my fears is that during the COVID pandemic, lots of people who came in with breathlessness were labeled as having COVID, whereas actually they had undiagnosed heart failure. Even this morning, actually, we received a WhatsApp picture of a chest X-ray from one of our cardiology registrars asking whether this was heart failure or COVID, and it's so difficult to tell from the chest X-ray. And I suspect there's been a proportion of people who've been mismanaged as COVID when actually they just had gross heart failure. But essentially, any patient with breathlessness, leg swelling, or lethargy should all trigger at least a suspicion of heart failure. And the NICE guidance that was updated in 2018 hammers this home and has a really simple algorithm for you guys to look at. The first test to think about, of course, beyond the clinical examination, the first objective tests to look at are an ECG and an NT-proBNP level. NT-proBNP is better than a standard BNP because it's more sensitive. And essentially an NT-proBNP of over 400 should trigger the suspicion of heart failure, together with, of course, an abnormal ECG. In terms of your investigation of the breathlessness side of things, of course, you're going to do a chest X-ray as well. And again, those key things are really what NICE have said in their new guidance. So if you suspect heart failure, you start off with your history and examination. You measure your NT-proBNP level, you do an ECG, you think about other causes. So you get your chest X-ray, you're thinking about peak flow or spirometry. Obviously, spirometry is a bit more difficult now, as is peak flow, given you know, the COVID pandemic. But certainly, you're going to think about those things and the other respiratory side of things. But actually, you know, an NT-proBNP level really is easy in terms of giving you that clue as to what's going on. The next line, so if your NT-proBNP level is over 2000, that suggests that there's acute myocardial strain and really something urgently needs to be done. So refer the patient on urgently to be seen within 2 weeks. And this is, you know, obviously the NHS relevant practice. If the NT-proBNP level is between 400 and 2000, then the normal NHS route is for someone to be seen within a 6-week time frame. Now, sadly, again, you know, working in the NHS, this doesn't always happen. I'm quite lucky where I am at Imperial. I do a community heart failure service, and we're extremely lucky to have 7 fantastic heart failure nurses who really help with are patients getting seen within that 6-week time frame. But certainly there's patches across London where they don't have access to the heart failure nurses. And so it's the cardiologist as a lone wolf trying to battle through lists of patients. So the access, it can be limited, but the ideal scenario is that the patient gets seen within 6 weeks once they have that elevated NT-proBNP level. If the NT-proBNP level is under 400, you should think again as to whether really heart failure is the diagnosis. Now, I mentioned very briefly that NT-proBNP looks at acute stress of the muscle. So essentially, I have patients who have, let's say, an EF, an ejection fraction of 30%, but have been like that for the last 10 years and are extremely stable on their heart failure medications, and their NT-proBNP level could well be under 400 because they've just got really well managed heart failure. So it really looks at whether this is potentially a new diagnosis in a symptomatic patient. So it's really good to sort of understand that differential. Once the patient has had that NT-proBNP and they've had their echocardiogram and a specialist assessment, will either confirm heart failure or say, this isn't heart failure, please think of something else. So once you've done your echocardiogram, or let's say you refer, of course, to Welbeck for your echocardiogram, the echocardiogram will look something like this, and you'll get an echo report saying, good left ventricular systolic function, mildly dilated left atrium as your echo report. Or alternatively, you could get something like this, showing valve disease, either significant or non-significant valve disease. Or you're going to get something like this, showing potential hypertrophy of the septum, and you're going to think about the cardiomyopathic route. Or you're going to get something like this, where here you can see, and sorry, I should have pointed out, this is the left ventricle here, this is the mitral valve, this is the left atrium. So here, when you look at the squeezability or contractility of the left ventricle, it's obviously clearly a lot worse here than it is here. So obviously there's been lots of iterations in terms of nomenclature in terms of for heart failure, but the categories that we've stuck to are heart failure with reduced ejection fraction, or HFrEF, and this has historically been just known as systolic heart failure. And this is where the ejection fraction is actually under 40%. And then the European Society of Cardiology came up with this extra category of HFrEF, or heart failure with mid-range ejection fraction, which is an EF of 40 to 50%. Now, they came up with this category because actually we don't really know how to treat these people that well. A lot of the clinical trials for the heart failure medications were actually done in people with an EF under 40%. So this is a bit of a gray area with some, movement in that area at the moment. But really, as clinicians, what we tend to do is link them all up to the heart failure with reduced ejection fraction category and treat them with pretty much the same medications, because we don't know, obviously, if they're on their way down or on the way up. The most difficult group to deal with is, of course, the heart failure with preserved ejection fraction, also known as HFpEF, also known as diastolic heart failure. And I remember this really only became a concept, 20 years ago, 15, 20 years ago, whilst I was training, that this category even existed. And this is basically for your people who are symptomatic of heart failure, so have the leg swelling, have the breathlessness, but have a normal ejection fraction. And again, the guidelines suggest that really what we want to do is look for alternate signs that the heart is under some degree of strain. And that is with your elevated NT-proBNP level, or looking at some sort of structural adaptation of the heart, be that in terms of left ventricular hypertrophy, so you can see the muscle is hypertrophied, or LA dilatation. So let's say the patient has significant hypertension, poorly controlled hypertension. They might be in the early stages and haven't quite developed that hypertrophy as yet. But you can imagine if your blood sitting in the mitral valve, sitting in the left atrium, going through the mitral valve into a stiffer left ventricle, the pressure is going to be quite high. So you get a higher left ventricular end diastolic pressure. And so the left atrium, as a thin compliant chamber, tends to dilate out. So you might not see diastolic dysfunction written on your echo report, but a dilated left atrium is a giveaway that something is going on. There's undertreated hypertension or undiagnosed hypertension, patients perhaps obese, or potentially, as you've heard, they may have AF. So there is some sort of structural adaptation to the heart with heart failure with preserved ejection fraction. And that's really what we're looking for when the patient had an echo. trying to bring it back to think about etiology. What are the causes of heart failure, and really does lifestyle make a difference? I sort of came up with this schema of where there are certain etiologies that are just HFrEF or just HFpEF. And again, HFpEF is the diastolic heart failure, HFrEF is the systolic heart failure. And what really falls in the middle of both of those and could cause either. So when you're thinking about HFrEF, some of the more common ones, of course, they're not exhaustive lists. Genetic, so dilated cardiomyopathies, inherited cardiomyopathies, that sort of thing. Alcohol is a big cause for heart failure with reduced ejection fraction, especially in some of the community clinics I work in. Idiopathic, sadly, there's a lot of patients with heart failure with reduced ejection fraction where we can't find the cause. Infection, things like myocarditis, which we can of course pick up really well with cardiac MRIs, and drug-related, so anthracyclines, obviously you've all heard of chemotherapy-related cardiomyopathies, they would again fall in this category. When we think about HFpEF or diastolic heart failure, really the key things are, funnily enough, what you've just heard from Mark: hypertension, diabetes, obesity. You could probably throw AF in there, although I put that in the middle, and things like CKD. So really it's those lifestyle factors that are really key for HFpEF. And of course, the biggest one, ischemic heart disease, falls in both categories. It can cause, of course, a scar after a heart attack and reduce your systolic function, or you can still have scar in the heart without a reduced ejection fraction and have fluid overload secondary to that. AF is, of course, a huge one. If you don't send your patients to Mark and they all end up with fast, uncontrolled atrial fibrillation, then they will develop left ventricular systolic dysfunction after that. And that's when I see them coming in as acute patients. So again, last week at Chelsea Westminster, we had about 3 patients come in with fast, uncontrolled AF and dilated and impaired ventricles. Infiltrative cardiomyopathies like amyloid can cause both HFrEF and HFpEF, and valve disease can also lead to both as well. So trying to tail it back to thinking about the causes and what's reversible. Alcohol, of course, ischemic heart disease, AF, hypertension, diabetes, and obesity. So can lifestyle significantly reduce your likelihood of developing heart failure? I look at ischemic heart disease as a combination of lipids and endothelium. So you can for sure reduce your lipids with lifestyle. You can for sure improve your endothelial function with exercise. So if you've got a high lipid level, but a really healthy endothelial lining of your vessels, of course, the lipids are less likely to stick onto a healthy lining of the endothelium. Whereas if you've got really unhealthy endothelium because you've been smoking your whole life, then the lipids that you do have are much more likely to stick. And of course, it's the combination of those that lead to ischemic heart disease. So for sure, lifestyle can significantly impact ischemic heart disease. Alcohol, of course, atrial fibrillation, as you've just heard, and hypertension, diabetes, and obesity, which I'm sure you'll hear more about. We all know, very clearly that dietary changes and exercise can almost reverse diabetes. Of course, that's true for obesity as well. And of course, hypertension, diabetes are intricately linked with ischemic heart disease and of course with atrial fibrillation as well, creating this vicious cycle. So again, this is a reference slide for you to come back to when you need to. But the key thing I want to highlight is at the top, if you see a patient with fluid overload, regardless of HFpEF or HFrEF, the key thing is to give diuretics to help relieve that extra fluid. And then again, central to both of these, if you follow both lines down with HFpEF as well as HFrEF, is cardiac rehabilitation. So that's an important thing which I'll touch upon. Again, this is there for you to have a look at. For those of you who haven't dealt with a heart failure patient in the last 20 years, the only really things that have changed are this new drug called sacubitril valsartan or Entresto for ease of use. And I am a big fan of Entresto and I use it in a lot of patients. So anyone with an ejection fraction of under 35% who are at all symptomatic, I immediately switch on to Entresto. So I've seen great benefits in terms of symptoms, and of course the clinical trial shows significant benefits in terms of outlook. Again, a reference slide for you telling you what was updated in the NICE guidance. Everyone with heart failure needs continuous monitoring. That's clinical assessment, review of meds, checking the bloods at 6 months, 6 monthly as a minimum. Exercise-based rehabilitation does help, reduces all-cause hospitalization, heart failure-specific hospitalization, and quality of life improvements as well. And there are rehabilitation classes that are graded dependent on how bad your patient is. So with my patients who are, wheelchair bound, they will still have rehabilitation classes, but it'll be seated based, so arm movements and that sort of thing. So it really will be tailored to your patient. So that's really important. So can lifestyle significantly improve your morbidity and mortality after developing heart failure? Yes, you've just heard exercise does make a difference. So the answer is yes. I'm going to very quickly move on to valve conditions before I run out of time. The commonest valve conditions that we think about valve stenoses or valvular regurgitation. Valve stenoses, especially in the UK, tend to be either calcific or perhaps less likely rheumatic. Valvular regurgitation tends to be degenerative or functional. And then, of course, you've got your congenital valve conditions like bicuspid aortic valve, and then you've got infective endocarditis. So that's really a broad brush of your different valve categories. And I've got some pretty pictures in here just because I can, just to show you a nice TOE showing really quite severe mitral regurgitation coming through that mitral valve. And one of the reasons we would do a TOE after 7 days of isolation in the current climate is to really get an idea of what the pathology is behind the valvular regurgitation, have a look at whether the valve is repairable or not. You can get quite nice 3D pictures to really give you that greater understanding of the valve and what it looks like and where the problem is. So here for this patient who really does have very severe mitral regurgitation, you can see in the middle there in that 3D image that there's a failure of coaptation. There's that gap in the middle just there where there's that significant leak coming out. And of course, this is a very craggy valve. So you're going to find it very difficult to repair this valve. This is going to be a mitral valve replacement. So can lifestyle make a difference here? It's hard. Good blood pressure control prevents against progression of a dilated aortic root. And that's a dilated aortic root could theoretically lead to stretching of the annulus around the aortic valve and make you slightly predisposed to aortic regurgitation. Of course, infective endocarditis could be related to lifestyle if you're injecting drugs. And of course, good dental hygiene is important for prevention of infective endocarditis. So apart from warning people not to inject intravenous drugs, which hopefully would be obvious, can lifestyle significantly alter your likelihood of developing or alter the progression of valve disease? The answer is really no. And there's not much you can do once you've developed valve disease to stop that. So, I've had patients ask me when I tell them they have calcific aortic stenosis, say, oh, I shouldn't have drunk that much milk. And of course, that's not the case. It doesn't work like that. Thanks very much. So yeah, we do obviously lots of imaging modalities at Welbeck. We've got everything available that our chair Mark also is involved as well. So yeah, and we've got all the latest stuff, the CTCAs with low dose radiation. So yeah, I'll stop there.
Great, thank you very much, Sunthar. Another great talk. So we'll swap over now to our third and final talk from Neil Chapman, who is a hypertension and risk factor specialist. Over to you, Neil. Neil, you need to unmute your microphone.
Sorry. Welcome everybody, and thanks Mark for the introduction. So I'm talking about risk factors and prevention, and I'm framing this in the context of the current COVID situation. So I'm going to talk a little bit about risk factors and their influence in COVID. I'm going to a little bit more detail about the renin-angiotensin system and ACE inhibitors and ARBS, and are they safe? Some general implications for management of risk factors at the moment, and then a little bit about beyond traditional cardiovascular risk assessment. So very early on this year, and as the pandemic took hold, it was apparent that high blood pressure, diabetes, and other cardiovascular risk factors appeared to be associated with worse outcomes. And then pretty early on as well, there was some concern that ACE inhibitors and ARBs may be mediating this increased risk because lots of hypertensives and lots of diabetics were taking these drugs. And this was picked up by the lay press, and headlines such as this in the Daily Mail were rather unhelpful. So medicines taken by 6.6 million people could raise the risk of day-to-day coronavirus symptoms. They may lead to worse illness. They increase the amounts of enzyme the coronavirus uses to infect the body. So unhelpful. Unfortunately, various guideline groups got together very quickly and put out statements saying that the situation was unclear, that these were drugs which are known to improve prognosis and therefore don't stop them. So these are early data from Chinese studies up to the end of February, and these are all unadjusted observational data, but all of them suggesting that high blood pressure, diabetes, respiratory disease, and cardiovascular disease increase the risk of severe COVID. So this is a graphic which tries to think about why that might be the case. We know that age is a very potent risk factor for severe COVID. And obviously you collect cardiovascular risk factors as you get older. So it could simply be that that's the reason why in observational studies, risk factors seem to be associated with worse outcome. But there are ways in which you can explain this. Older people are more likely to have cardiovascular disease, whether clinical or subclinical. They're more likely to have cardiovascular risk factors, and we know that cardiovascular risk factors cause systemic inflammation, hemodynamic changes, and changes to your coagulant status. So everything is a perfect storm, potentially a vulnerable heart being acted on by risk factors mediated through inflammation. So there's many reasons why these risk factors may cause worsening of disease. These are some interesting data which were only published last week in Nature. Now this is the Open Safely study, which is the Ben Goldacre group. Open Safely is a health analytics platform which is connected to 17 million patients in England. That's apparently 40% of GP patients. And what they've looked at is COVID-related death in relation to specific risk factors. And they had almost 11,000 deaths. So largely they confirm what we've seen elsewhere. So age is a very strong risk factor. Being a male is a strong risk factor. Being overweight, there's a theme here for AF, heart failure as well. The more overweight you are, the greater your risk of dying from COVID. All non-white ethnicities associated with increased risk. Level of deprivation associated with increased risk in a stepwise fashion. Diabetic control associated with increased risk. And chronic heart disease, modest but significant increased risk of death. There were two perhaps unusual findings which they've explored in more detail, and those are shown there. So both smoking and blood pressure in their fully adjusted analyses came back as not harmful, and in fact borderline benefit. So they've looked at each of these in turn. What they found is that for smoking, if they adjusted for age and sex only, smoking was bad for you, as we might expect. And it was felt that the dropout of smoking causing significant harm was because when they corrected for all the things they were correcting for, it was dropping out because smoking causes chronic respiratory disease, and when you correct for chronic respiratory disease, the effect of smoking disappeared. And for blood pressure, the simply adjusted figures show that high blood pressure was harmful. They explored this further and they found that there's an interaction with age. So hypertension appears to increase risk up to the age of 70. After the age of 70, it's no longer a risk factor. So yeah, I think this just confirms everything else that we've seen, but perhaps the numbers don't look quite as bad after you take out age out of the equation, and age remains the biggest risk factor. So if we go to the renin-angiotensin system and return to this Daily Mail headline, this is the renin-angiotensin system, and it's a complicated slide for which I apologize, but I'll try and break it down. So on the left, we've got entry of the COVID virus into cells, and that is mediated by a membrane-bound ACE2 enzyme. Now, ACE2 is an enzyme which is thought to be upregulated or increased by treatment with ACE inhibitors and ARBs, although whether that's strictly relevant to lung tissue remains unclear. So there's potential increased risk of viral entry with ACE inhibitors and ARBs. And on the right, you've got the renin-angiotensin system. The one we all know well is in red. So angiotensin 2 has got a variety of harmful effects on the lung, and features of severe COVID infection do appear to be very similar to the effects of angiotensin 2 on the lung. So that's thought to be a possible mechanism of some of the damage done by COVID infection. But there's also a counter-regulatory and beneficial arm to the renin-angiotensin system. That's the angiotensin 1 to 7 and 1 to 9, which are created by cleavage of angiotensin 1 and 2 by our old friend, the ACE2 enzyme. And ACE2 is increased, as we said earlier, by ACE inhibitors and ARBs. So we've got a balance here between possibly increased entry of virus into the lung cells via ACE2 and possibly protective effects promoted by ACE inhibitors and ARBs and also mediated by ACE2. So there's scientific equipoise here. So we still don't know. So studies were done very quickly to go and look at whether or not there was any evidence of ACE inhibitors and ARBs being harmful. And these are a variety of large observational studies, one from New York, one from Italy, and one from Denmark. And the sharp-eyed amongst you will have noticed that the New York one was actually one of the articles that were withdrawn with quite a lot of publicity because they were done by the now discredited Surgisphere group. But either way, they got the same results as everyone else, which is that there is no evidence that ACE inhibitors and ARBs increase the risk of either of contracting or severe COVID, and editorials reiterate that. So what are the implications of COVID for CVD prevention? Age and risk factors do appear to increase the risk of severe disease. So optimizing our risk factor control, though unproven, seems sensible just to improve our baseline cardiovascular health and our overall health as well. And don't forget that our clinical frailty score may have an impact on how we get managed if we happen to end up very sick in hospital. So we should all be aspiring to be as healthy as possible. So treat risk factors as per usual using drugs with the usual treatment algorithms and lifestyle. Lifestyle, we've heard it before today and we'll keep saying it. Your fat intake, your salt intake, lack of fruit and vegetables, and lack of exercise are all known to have impacts on blood pressure and cardiovascular health. We know that patients aren't very good at this. We know that we're not very good at getting our patients to be good at lifestyle, and we're not helped by the press coming up with frankly perverse and unhelpful headlines such as these. So this is the effects you can expect to see potentially on blood pressure specifically, but with knock-on effects on cardiovascular health. You can achieve significant blood pressure reductions if you can manage to do these things. So healthy diet, lots of exercise, low salt intake, moderation of alcohol, and weight loss. During lockdown, I think a bit of a mixed picture. There's certain threats, certain opportunities there. And at the bottom there, you've got quarantine 15, which is the apparent 15-pound weight gain, which has been observed in some populations. I think that the 15 pounds has rather been disregarded now. And I think overall, patients I've been speaking to recently, most of them have probably, their lifestyle has deteriorated and they've gained some weight, but a fair number have managed to maintain their previous level of health, and a few have managed to actually improve things. Just a quick word about blood pressure monitoring. At home blood pressure monitors have been around for a while. Lots of our patients have them, but we haven't really been using them systematically, and I think now is the right time to do so. It is important, though, when patients measure their own blood pressure, that they do it right, and that means having the right bit of kit and particularly the correct sized cuff. This was an Amazon search I did yesterday, searching for home BP monitors, and on my first screen there were 19 monitors, only 3 of which were validated, and none of the 19 made any comment about cuff size, and only one of the 3 validated monitors was supplied out of the box with a cuff suitable for anything but a standard arm. So it is important that patients buy the right thing. There is the British and Irish Hypertension Society website have a list which isn't particularly user-friendly. We've developed a shorter list which has got information about cuff size and connectivity, and I'm very happy to share that along with some guidelines on giving patients about measuring their own blood pressure. But it is important that we get this right. So moving on to finish with about cardiovascular risk factors and assessment, we know from some fairly historic data now into heart and stroke that most of the population attributable risk for cardiovascular diseases, both cardiac and stroke, can be explained on the basis of traditional cardiovascular risk factors. And we've got risk calculators, but we know that these are imperfect. They don't capture all of the risk, and they may underestimate or they may overestimate risk. There are plenty of new markers that are being looked at, including genes, but so far these have proved to provide marginal benefits. But one of the things that can be useful is coronary artery imaging with calcium scoring, or sometimes with coronary artery CT coronary angiography as well. And this is a shortened and simplified diagram to help or to consider where coronary artery calcium scoring and or angiography may be, CT angiography that is, may be helpful. I would ignore the percentages in the top line because this is an American document, and I think intermediate for me is the 10 to 20% range, but there may be some people below the 10% range who you would consider for further investigation. So things, looking at this, people who are in the intermediate range or in the upper end of the lower risk range, think about risk enhancers. So those are family history, high LDL cholesterol, CKD, metabolic syndrome, and a variety of others. In those who clearly need enhanced risk factor control, then that's straightforward. If you're in any doubt, or if the patients are unkeen, then that's where coronary artery calcium scoring with or without CT angiography may be helpful. We know that having a coronary artery calcium score of 0 is reassuring. Equally, we know that anything above 0 is associated with demonstrable risks. So it's worth thinking about where that could fit into your patients. So I'm going to finish off with a case, and thanks to Sunthar for this. This is a 46-year-old banker who's asymptomatic and very fit, does a lot of cycling. But he's got a family history of premature coronary disease. He's known to have hyperlipidemia, and the issue of statin has been discussed previously, but he wasn't keen, so it was dropped. And he's now returned for further advice. On the basis of his risk profile, including a normal blood pressure, his Q risk is only about 5. But because of his very strong family history, he went on for imaging, and his CT coronary angiogram there shows a severe stenosis in his LAD artery. So he's gone on to high-dose statin therapy. Further investigations have shown a positive stress echo, so he's having further investigations and potentially treatment. So in conclusion, we know that cardiovascular disease itself and various of its risk factors are associated with worsening prognosis in COVID-19 infection. Optimizing our general and cardiovascular health at the moment seems like a particularly sensible thing to do at the moment. Think beyond standard cardiovascular risk factors and consider imaging if in doubt, and where necessary, do manage risk factors aggressively. Thank you.
Great. Okay, well, 3 fantastic presentations, and we've got just under 10 minutes left, so I'll move straight over to the Q&As, and we've got some questions in. So the first question is to Neil, and what's the definition of a validated home blood pressure machine? And then just another one, could you share the infographic, which I'm sure we could?
Yeah, well, we'll certainly send that around, and we can provide we'll provide a copy of the whole slides, but you can have a PDF of the blood pressure stuff particularly. So validated just means that it's been independently validated in a peer-reviewed journal, and the British and Irish Hypertension Society have a blood pressure measurement working party who screens all of these to make sure that they have been done to the correct standard, and you'd be surprised how many haven't. And if they've been independently validated, they are listed on their website. If they fail, they're not.
Okay, great. The next question I've got, so we'll chop and change amongst the panel, so is for Mark Earley. So on the link between BMI and AF, there is increased doubt on usefulness of BMI measures. Are there links between any other types of obesity measures, such as height-weight ratio and AF, that we should think about?
Yes, I mean, there has been some criticism of using BMI as the only measurement for assessing this. Weight per se is a great continuous variable to measure and to study. BMI is also useful. Lean body mass is another way of doing it. These have all been looked at. I don't have all the exact details, but yes, there are other ways of looking at that for sure.
Thank you. Okay, I've got another one for Neil, which is, so are ACE inhibitors okay in COVID? I think we sort of...
Yes. So I gave a webinar quite early on in the process of the pandemic, where I suggested a new hypertension algorithm, which was for new patients. So avoiding use of drugs such as ACE inhibitors and ARBs, because at that stage, getting patients having blood tests was quite difficult. But throughout, the advice has been continue them. And these days, I would have absolutely no hesitation about starting people and treating people as normal.
Great, I think that's very helpful. I just wanted to ask Sunthar a question. Sunthar, you talked about the difficulty with shortness of breath and the compounding, if you like, of making the diagnosis with COVID, and obviously that presents with shortness of breath. Do you think that we have seen a reduction in the presentations with heart failure, and that in the next 6 months we're going to get a surge in heart failure presentations?
Thanks, Mark. Yeah, absolutely. I think it was well documented in the press, and you probably heard stuff come out of the British Heart Foundation saying that the number of people going into hospital with heart attacks had dropped significantly. And the number of, when you look at the number of deaths coming out the other end, so when you look at the data comparing, let's say, a month during COVID to a month from the year before, the number of people who had heart failure related death listed as their cause on their form was significantly lower, and that just it just can't be the case. So I think there was an under recognition. I think there was an under presentation of patients going into hospital both with heart attacks and with heart failure. And actually, I've set up an audit across hospitals in northwest London to have a look at all new heart failure referrals coming from now to December, to actually see if we can pick up those people who've stopped not come in because of their chest pain and who now have heart failure. So spot on, there's definitely been a huge reduction in patients presenting.
Okay, and I mean, you mentioned Entresto, which is a fairly new treatment. I mean, with new patients, it's fine. What about patients who say are reasonably well controlled on either their lone ACE inhibitors or ARB, or their ACE inhibitor plus beta blocker, etc.? Are you switching those over, or is it just for new presentations?
I mean, essentially, if I can beat a symptom out of them, then I will switch them. So, the line of questioning is, are you breathless when you're walking on the flat? If that's no. Are you breathless when you're walking up the stairs? No. Would you be breathless if you were walking upstairs with an elephant on your back? Yes. Okay, great. I mean, essentially the data for switching, the only reason, this question was asked at the British Heart Failure meeting as to why the NICE guidance didn't switch to just, or the recommendation wasn't that people just switch to Entresto straight away. And the answer from the person who wrote the guidance was that literally the trial had been designed in such a way that people were on the ACE inhibitor first before then being switched over. And that's the only reason pretty much why they weren't started on why it didn't say that in the guidelines. But for sure, if I can get a symptom out of a patient, I will switch them on to Entresto, because the data is clear that it reduces hospitalizations, it reduces heart failure related death. And similarly, as you know, the data is now there for the SGLT2 inhibitors with renal disease and diabetes to start SGLT2s for improvement in heart failure outcomes.
Great. Okay. Mark, I just wanted to pick up with you. I think your second or third slide had the word aspirin on it with a great big line through it. I mean, as far as I know, aspirin has no role in the management of AF. Is that Is that the current thinking?
Yeah, that's absolutely right. Perhaps when we were medical students, it was still a #1 treatment for preventing stroke in AF, and I think that message is hopefully well and truly out there now, that it's of no use whatsoever. In fact, it's harmful without providing any benefit to prevent stroke in atrial fibrillation. It may still have a role in vascular disease. I think there's even some uncertainty on that. And so patients who also have a high burden of vascular disease may benefit. But as a treatment to prevent stroke in AF, it is of no value.
Great. And I mean, you mentioned warfarin versus DOACs. I mean, most of us would use DOACs. Apart from where DOACs are contraindicated, are there any other sort of subtle preferences for using warfarin, or is it pretty much DOAC first, DOAC second, DOAC third? If you're really struggling, go for warfarin.
Very much so. And I think people are really, well, I mean, warfarin causes all the problems with anticoagulation. Other than those patients with severe mitral stenosis or metallic valves where the DOACs are contraindicated, then we would always choose a DOAC now. And the fears of bleeding and not being able to reverse it and things like that, I think people have become very comfortable with their use now, definitely in secondary care, and I think very much in primary care as well.
Great. Okay. We've just got time for one last question that came in, and it's for Neil. Is there any link between one-off cardio issues and COVID, for example, myocarditis? So,
sorry, so is there any link between
one-off cardiac issues and COVID, for example, myocarditis has just come in as a question.
I'm not sure what the implication of. I mean, certainly myocarditis is happening as a result of COVID.
Yeah.
I think that we don't yet know whether or not the association between cardiovascular risk factors and COVID morbidity is all mediated via cardiac problems and cardiac ultimately causes of death, or whether it's more complicated than that. We've seen such a lot of research come out in such a short time that I think it's going to take a long time for this all to shake down and work out. But I think anyone who's got a history of cardiac disease should regard themselves at greater risk than someone who hasn't.
Great. Okay. Well, we're bang on 2 o'clock. So I think at that point, I'll draw it to a close. So I'd like to thank you all for joining us. And I'd like to thank again our three great speakers, Mark, Neil, and Sunthar. And yes, thank you very much for joining us, and have a great afternoon. Thank you and goodbye.
Thank you.